Good evening, friends. Welcome to this Tuesday evening academic sessions from Yashoda Group of Hospitals. We have been bringing topics of your interest and current concern. And this journey has been there for last 4 years or so. Today is a special day because we are discussing one of the most concerning topic to most of us in intensive care unit and infectious disease specialists. It's no more confined to one geographic location. It's now a global concern and also being a threat to the mankind. From the day of the discovery of penicillins, we have been listening about this concern, and over the last decade or more, this concern is gaining its seriousness more and more from geopolitical system to clinical concerns and clinicians. So we wanted this topic to be discussed, and when we discussed about this topic like the gram-negative resistance and microbial resistance and the treatment option in India currently and in future, we had none other than Dr. Balaji sir, who has been professor in clinical microbiology in Christian Medical College, Vellore. And I can say he's been most sought out microbiologist and clinical researcher for the antimicrobial resistance in the last maybe a couple of decades or so. We are happy and proud that he accepted our invitation and being with us to actually share his knowledge and his opinion on gram-negative resistance and treatment options in India. So it was a privilege and proud honor for us to have you on board and being there for this presentation. Thank you, Balaji, sir.
Thank you. Thank you, Dr. Venkat, for your nice words. For the next...
and just one more minute, sir.
Yeah, sure, please, sir. Sorry.
I request, I invite Dr. Mona Lisa Sao, who is the senior consultant, the infectious disease specialist in the Yashoda Group of Hospitals. She covers both the three units in Secunderabad, Somajiguda, and Malakpet. She has been a part of All India Institute of Medical Science for both post-graduation and in specialty training, and been a part of the academic session in different platforms and in our sessions also. Welcome you on board, ma'am.
Thank you.
Dr. Karthik, can you just switch on your camera? So Dr. Karthik Vedula is consultant ID infectious specialist in our same institution, Yashoda Hospital, High Tech City. And he has been there with Yashoda Group of Hospitals for the last 3 years or so. He has been in the front line of managing our cases in the critical care department and the other specialties, and was keen to be a part of this antimicrobial stewardship and others. So welcome you on board, Dr. Karthik Vedula. Sir, unmute yourself.
Good evening, sir. Good evening, everyone.
So we have a platform on board. We have a clinical microbiologist and researchers to present, and both our ID specialists will give their inputs at the end. Over to you, Balaji, sir. Thank you.
Okay. Sure. Thank you. So for the next few minutes, I would like to talk about the gram-negative problems. And most importantly, a couple of issues I'm covering in this lecture. One is how the gram-negative resistant is evolving and how we can manage with the current drugs, what is available, readily available, what we are using it. And second important area which I will be covering in this session is, in near future, what are all the best optional antibiotics available for different problems. So when I say in the near future, I'm expecting it by next year, by this time, at least a couple of drugs should be available. Even though it has been approved and readily available and being used elsewhere, that is in the Europe and America, still it has not reached India. The main reason why it has not reached India is, one is regulatory approval delay, and preparatory phase from the respective pharmaceutical companies have delayed that one. Otherwise, by this time, we would have had those better drugs, which would have saved many thousands of lives. But unfortunately, we were a little late. But I would like to explain what are all the new drugs which will be available in near future and how that will help. But again, all the new drugs also may not be completely ideally will suit our situations. Still, we may continue to have problem. So this is the current scenario, which is quite unique to India. You cannot compare our country with Europe or America. They have a different problem. Their literature may not help us to give best of therapy. So it's the most important is we need to understand our resistant mechanism and our drug of choice. So that's more important. So these are all the 4 common drugs which kills more patient in the ICU. One is E. coli. And here, ESBL E. coli can be easily treatable with meropenem. Unfortunately, if it is carbapenem-resistant, then you need to choose other antibiotics. That's where I'm going to say. And 90% of the CREs, that is overall CREs are only 10% among every institution's collections. Maximum it will be 10%. I don't see anywhere going beyond that. And there are certain problems with the CREs. It's not easy, simple to treat because it is complicated for a newer therapy for the simple reason, not only New Delhi Metallo-beta-lactamase. In addition to New Delhi Metallo-beta-lactamase, there is a PB, penicillin binding protein 3 insertion is there. And apart from this, AMP-C is there. So this 3 contributes to the failure of the presently available drugs. So we will see it in detail later. And Klebsiella, among the carbapenem resistant, 80% of the carbapenem resistant Klebsiella, it is dual enzymes, NDM and OXA48. Among the OXA48, there are 2 variants are there. One is 181 and another one is 232. The problem with this 2 variant is these 2 variants are exclusively seen more in India than any other country. And these 2 variants are not that easily treatable. That is another challenge. And when moved to Pseudomonas, again 80% it will be susceptible. And in the 20%, whatever is resistant, what we come across, almost close to 100% of the 20% resistant, carbapenem resistant, is due to NDM. Again, it's metallo-beta-lactamase. So that's the problem. Otherwise, in Europe and America, it's not due to NDM. It's majority, it's due to efflux and porin. In India, efflux, porin and NDM are there. So that's the problem with the Pseudomonas. Then moving to Acinetobacter, again, almost 80% of the Acinetobacter seen in India are carbapenem resistant. And irrespective of the best therapy, we try and give 40% mortality is seen. So that's the situation of Acinetobacter baumannii. So essentially, all the 4 organisms, the major problem comes with the New Delhi Metallo-beta-lactamase production. So for us, the only one killer enzyme, if easily I can say 90% of the or 95%, the killer single enzyme in India is New Delhi Metallo-beta-lactamase. And the New Delhi Metallo-beta-lactamase, many variants are there. And in India, for enterobacterials, it's majority the variant 5. And for non-fermenters, it is NDM1. So that's why I said NDM fuels India's superbug crisis, driving carbapenem resistant in enterobacterials and Pseudomonas. And here I have missed Acinetobacter baumannii because whole world doesn't think Acinetobacter baumannii has got NDM, but 100% sure in India, 40% of the carbapenem resistant Acinetobacter baumannii along with OXA23 NDM is present. So that's but single enzyme, if you know and if you can manage the NDM enzymes, then you will be very successful with the therapy. So how the New Delhi metallo-beta-lactamase can be overcome? So now we do have no more the beta-lactamase inhibitor like sulbactam, the clavulanic acid, tazobactam are not great. So the newer beta-lactamase inhibitor like Avibactam, Relibactam, Nacubactam, Zidibactam, Darlobactam are the best inhibitors for the present problem. So that's why I'm saying here is the old amoxiclav, that clavulanic acid, ticarcillinic clavulanic acid, sulbactam, that's are all not great now at present except Acinetobacter baumannii. The newer generation beta-lactamase inhibitor like Avibactam, Relibactam, Nacubactam, Zidibactam and Darlobactam. Among these newer generations, already Avibactam, Relibactam and Darlobactam are available elsewhere. In India, it's only Avibactam available. And we may get in within a year Nacubactam combination and Zidibactam combination. So these are all the lifesavers. And you can see here, based on the resistant mechanism to E. coli, Klebsiella, Pseudomonas, Acinetobacter baumannii, various drugs has got different coverage. So first you need to know the identity of the organism, then you need to know the resistant mechanism, then only you can choose the right antibiotic. So for enterobacterials, I can easily say Aztreonam Nacubactam and Cefepime Nacubactam and Cefepime Zidibactam are the best. And when it comes to Pseudomonas, again Cefepime Zidibactam is best. And when it comes to Acinetobacter, Cefepime Zidibactam plus Sulbactam will help. So this is how I have positioned, and I will talk a little more on Cefepime Zidibactam subsequently, which are expected to be available in India at least the end of this year or sometime anywhere after October. I think it should be available in India. So all these beta-lactamase inhibitor, unlike enzyme inhibition, this has got a beta-lactam enhancer activity. We don't call it as beta-lactam inhibitor, we call it as beta-lactam enhancer. You can see that Cefepime will act again on penicillin binding protein A. And if Cefepime is added with Nacubactam, this covers PB2. So Cefepime and Nacubactam, you can see it covers PB1A, PB1B, PB2 and PB3. So this is how it covers all the major penicillin binding protein, and due to this strong affinity, it can act very well. So these are all the affinities of various things, and based on this combination, you will see the effect. So now I would like to talk about two drugs, Aztreonam avibactam and Cefiderocol. Aztreonam avibactam, it's already available and we are using it. Cefiderocol, it's widely used, and that is the one of the most important antibiotic. Year on year, the sales are very high in US and Europe. So at present, the blockbuster antibiotic is Cefiderocol in US, but it's not available in India. It will be available soon, maybe definitely this year or early next year. So this is the susceptibility profile of E. coli and Klebsiella. The top row is E. coli, the bottom row is Klebsiella, and I have written it's the resistant mechanism, positive isolates we picked up for susceptibility testing. This E. coli has got NDM and PB3, and it may have AMPC also. Here it's NDM plus OXA48 for Klebsiella. So Cefiderocol definitely not great, because you can see 60% susceptible, 40% resistant. Aztreonam avibactam, 70% susceptible, 30% resistance is there. But in near future, next year, we will get Aztreonam Nacubactam. That will have 100% susceptibility. Cefepime Nacubactam, again it will have close to 100% susceptibility. Cefepime Taniborbactam, actually just couple of months back, it came closer to the FDA approval, and because of the formulation problem, this has been almost dead. So I think they could not overcome the formulation or potency retention of the drug. So that's the problem. It's not with the drug. The retention of the potency of the drug was the problem. So this has been almost killed after 20 years of research and successfully tested on human. It worked out well, but the formulation could not be retained with the potency. That's the reason this has been killed. And Sulbactam, Darlobactam, it works well for E. coli, though it is specific for Acinetobacter baumannii. And the most game-changing molecule is Cefepime Zidibactam. So this is susceptible, 100% susceptible to E. coli, 100% susceptible to Klebsiella, and it's almost 100% susceptible to Pseudomonas. And to great extent, it can cover even Acinetobacter baumannii. That's the great of Cefepime Zidibactam. So now I will add little more on Aztreonam avibactam. Why we have 30% resistant to Aztreonam avibactam and Cefiderocol? The simple reason is, apart from NDM, PB3 insert, AMPC, and porin loss. So major issue, ESBL separately, if it is there, easily treatable with meropenem. NDM alone is there, easily 100% it will get knocked down by Aztreonam avibactam. But along with this, presence of porin loss, PB3 insert or AMPC makes it a failure. So this is the biggest problem, but NDM ESBL is not a problem. So once this triple mechanism is present, even without NDM or ESBL resistant, IMIC clinical failure is essentially assured, they say. So now, having said that, so it not all the three will be present all the time together. So sometimes it will be only PB3. At the time there won't be any problem. It will be susceptible. ESBL, PB3, there won't be problem. Porin plus PB3, it won't be a problem. It all starts with the different these combinations, NDM, ESBL with PB3. And again, the insert, if it differs, then there will be a difference. From 4 to 8, it becomes, this is easily manageable with higher dose. But less than 16 is difficult to treat. And again, this combination also gives less than 16. The moment AMPC comes in, absolutely you can't treat these individuals. It's a major determinant, and you cannot focus on Aztreonam avibactam. You need to go further for cholesterol. So again, this all three, it's worst. But unfortunately, to diagnose presence of AMPC, PB3 insert, and porin loss, no test is available in the microbiology lab. So it takes a long time. This can be characterized in the research lab, but all the isolates cannot be done. And hence, you have, if the MIC is high, you assume that the major resistant mechanisms are in operation, and hence you should switch over. So don't try to characterize, and it's not possible to characterize what resistant mechanism. So you have to depend mainly on the MIC, and the MIC, if it is more than 8, then no point in depending largely on Aztreonam avibactam. You need to go for a colistin or Aztreonam avibactam plus fosfomycin for E. coli or tigecycline can be added. So now I will tell you the problem with the pivotal studies, that is phase 3 studies, which passed through the FDA and got it approved. But what is the problem for us is, for example, Aztreonam avibactam, they have done phase 3 studies, 2 studies. One is called Revisit, another one is called Assemble. They had hundreds of isolates tested or patients with that infection. But if you look at, they had a KPC or OXA48 and very low number, that is only in the entire phase 3 study, Metallo-beta-lactamase or NDM was present only in 7 patients. Again, in assembled study, the MBL positive were only in 12 organisms in 12 patients. And in the control arm, you can see very few. So further, I will give you the breakup. If you look at E. coli in revisit study, 50% failure was there. Again, in assembled study for E. coli, 50% failure was there. Whereas Klebsiella and Enterobacter was better. If you look at the assembled study, again 25%, Klebsiella pneumonia also failed, and the Enterobacterials 50% failed. So actually, when we see the resistant mechanism, which is very important for India, this drug is not very promising. So always you need to be watch out. So you may not get 100%, but 50 to 60% definitely you will be successful. So don't take it for granted. It's better that identification of the organism and MIC will help you, or even the simple susceptibility testing will help you. So you, even though you will start an empirical therapy, follow it up with the laboratory reports. Now I move on to the Cefiderocol. Again, Cefiderocol, two important studies helped to get the FDA approval. One is the PROVE, another one is the post marketing phase 4 study is the game changer study. But Cefiderocol, again, they looked for the OXA48 and KPC, majority of them. NDM were very little in the PROVE study. Game changer, mainly they looked for the NDM, especially in bloodstream infection. So you can see here in the PROVE study and game changer study, E. coli failure to Cefiderocol was almost 75%, whereas Klebsiella it's 40 to 60%. So that's why it's very clear the resistant mechanism what we see in India, it's not seen in East European countries or European countries and in America. So the result and the approval largely good for their country, but not for us. So all I would like to say is we need to have our own data, our own experiences shared through publication, and this information will keep us uh, to understand well and prescribed accordingly. Otherwise, we have to continue like now, where instead of giving monotherapy and having confidence, we are always by chance, we don't want to take a risk and we are giving multiple antibiotics. So look at the Cefiderocol again, even with Pseudomonas, failure rate was 33%, game changer 50. For Acinetobacter, again improved study 60% failure, game changer 62% failure. So definitely, unlike other resistant mechanism, NDM resistant mechanism, therapy with the Cefiderocol or Aztreonam avibactam is not that great. So you need to be watchful. And this is the game changer study which was published 1 month back. You can see standard of therapy is where polymyxin they have given. So you can see that when you give Cefiderocol, the mortality was 19% at day 14, whereas with cholesterol only 7%. Again, in Acinetobacter, with Cefiderocol it's 9%, whereas with the cholesterol it was slightly higher. And look here, cholesterol is it's almost 50% in Acinetobacter, whereas Cefiderocol 45%. And here 32% versus 23%. So it's very clear that we need to be watchful with the NDM. So now very recently, all these days we were telling with great confidence, E. coli is the problem but not the Klebsiella. Aztreonam avibactam will be very successful. But recently, I have seen emerging resistant to Aztreonam avibactam also for Klebsiella. So how that has happened? Just I am giving two isolates example where we have characterized. In addition to whatever the enzyme I have said, here two enzymes more is seen, three enzymes are seen, CMY4, OXA10 and WEB24. So this plasmid has moved from some other organism to Klebsiella and multiple resistant mechanism. Look at the number of enzymes present in this isolate. So many resistant mechanism also codes resistant for Aztreonam avibactam. So the caution is don't take it for granted that Aztreonam avibactam will 100% work for Klebsiella. As of now, almost 90% it's working, but the emergence of this strain really alerts us. So we need to be watchful. If it is slowly it's moving, then we are safe. If this is rampant, then we will be having a problem. As of now, we have seen very few from Mumbai. These are all the Mumbai isolates, not even Vellore isolates. So other than Mumbai, I have not seen elsewhere. So this is the details of that study. So, okay, so that is about the Aztreonam avibactam, what we are having. Cefiderocol, I explained. When it comes, then we have to have our experience documented. Now I move on to the most important new drug which will be available next year, Aztreonam Nacubactam, Cefepime Nacubactam. So definitely this combination seems to be much better than Aztreonam Avibactam, what we have. So you can see that Aztreonam Nacubactam for E. coli with all the resistant mechanism, including the AMPC, it's 100% susceptible, whichever the guideline you take. And Cefepime Nacubactam also gives 100%, almost close to 100% susceptibility. And when Nacubactam is added to Cefiderocol, again it works very well. Cefiderocol alone is not good. Then Aztreonam avibactam, okay for enterobacterials, but not for with AMPC. So Cefepime taniborbactam out, and Cefepime Zidibactam, it's 100% susceptible. So these are all the new combinations which may be available and we can use it. So Nacubactam, you can see Aztreonam Nacubactam for E. coli, 100% susceptibility, and Cefepime is slightly lower than Aztreonam Nacubactam. This is for E. coli. This is for Klebsiella. Again for Klebsiella, both Aztreonam Nacubactam, Cefepime Nacubactam, with the dual enzymes or with the mono enzymes, it works very well. You can see here. Susceptibility is almost 100%. So the best new drug which we can expect better than Aztreonam avibactam is Aztreonam Nacubactam or Cefepime Nacubactam. These drugs are going to come Nacubactam as separate vial. We need to add this Nacubactam with Aztreonam and inject. Similarly, Cefepime will come separate, Nacubactam will come separate. You can add Nacubactam to Cefepime and you can inject to the individual. So you have a choice in which patient you can choose Aztreonam and in which patient you can choose Cefepime. By default in India, Aztreonam may be the better choice than Cefepime. If there is no NDM, it is only KPC and OXA48, then Cefepime combination will be good. Okay, then these people have finished their pivotal studies, phase 3 studies. There are two studies were carried out, integral 1 and integral 2. Both have shown non-inferiority to the best available therapy. So I don't want to get into these numbers, but still the numbers are very low, not that big. Nowadays, all the clinical trials, as we wish, they are not getting more numbers because the resistant mechanism of NDM is not seen the play in the region where they carry out this clinical trial. Okay, now I will come to the most important drug. This is the Indian drug, Indian discovered drug, and it's very close to approval in India, and it has been filed both in Europe and in US. So FDA is reviewing this drug and European Medical Agency is also reviewing. Once those two agencies and in India, all the three regulators approved, then this will be a game changer molecule. I am saying game changer because this is not highly good for all the resistant mechanism of E. coli, all the resistant mechanism of Klebsiella. So universally it's so good. And to great extent, even for Pseudomonas, it works very well, close to 100%. Only it needs additional support of Sulbactam to take care of the Acinetobacter baumannii. That's the situation of this Cefepime Zidibactam. And this is again a DBO with a dual function. It binds to PB2. And so this can overcome NDM plus PB3, NDM plus porin loss, NDM efflux porin and Pseudomonas derived cephalosporinase of Pseudomonas, and even the Pseudomonas resistant to ceftolozane tazobactam and ceftazidime avibactam, this drug will be good. And even for Acinetobacter baumannii with the dual enzyme NDM and OXA23, Cefepime Zidibactam will be good. So the phase 3 trial is over and the results are available, which I will be presenting in subsequent slide. So here you can see that Cefepime Zidibactam covers all the major mechanisms of all the important 4 pathogens. So Cefiderocol is limited, Aztreonam avibactam is limited, Cefepime, no need to talk, and ceftazidime avibactam is also limited. And we have tested this and we have published in all the international leading journals at various intervals for the past 10 years. And this is the Indian regulator study. So the government of India told them for immediate use to run a phase 2 trial bridging study and give the report. And for Cefepime Zidibactam, when they have tested for AP and VAP, they had almost 90% susceptibility. For intra-abdominal infection, 100%. Complicated urinary tract infection, 91%. And bloodstream infection, 100%. Overall, it had a 93.9%. So these results are with the Government of India and they will be approving at any moment. That's about the Indian study. And this is the global study. The study has been carried out in Eastern European countries. Some 4 or 5 countries participated in it. And there they found out Cefepime Zidibactam had a 98% primary endpoint clinical cure. Whereas when compared to meropenem, the control arm, 68 or 69% it was there. So nearly 20% difference was there. Hence, it's called superiority over meropenem demonstrated. So these results have been submitted. FDA is reviewing, and once they are satisfied with all the laboratory and the clinical findings, this will be approved. And this is one drug which will be immediately available in India. A novel drug usually takes 5 years or 6 years after launching in US or Europe, and it will be very expensive. So contrary to that, this is an Indian drug. It will be first available in India and it may not be that expensive. It will be cheaper here and it will be more expensive in Europe and USA. So phase study is over. Phase 2 is also over. Phase 3 also, 2 and 3 have showed the result. And Indian regulator are ready. Anytime this year it will be approved. USA also this year it will be ready. And EMA also they have submitted in December. Even in Europe it should be available this year. So this will change and it will help really all the intensivists to partially overcome the antimicrobial resistant problem at least for the next 5 to 6 years till other resistant mechanism emerges. But I should tell you that after Cefepime Zidibactam, there is no antibiotic closer to the spectrum available, even in the phase 1 study. So, if phase 1, phase 2, phase 3 usually takes close to 10 years or 7 to 8 years. So, no promising antibiotic has reached even phase 1. So, for the next 6 years, this is going to be the blockbuster. And if we are losing this drug, we don't have any other alternative. Again, we have to recycle the colistin or polymyxin. So that's the current situation. So unless some new development occurs in the next 8-9 years, we can see another new drug. Otherwise, it's a pathetic situation. So now I have given the comparison of the 3 novel drugs. Aztreonam avibactam, already we are using it. Cefiderocol, it may come very quickly, and Cefepime Zidibactam also it will be there. But the difference is Aztreonam avibactam recurrence is 18%. Cefiderocol even more, 32%, whereas Cefepime Zidibactam, it will be susceptible 100%. No recurrence, nothing. And not only it can be chosen as an empirical therapy because it covers even non-fermenters, Pseudomonas, Acinetobacter. Cefiderocol covers again non-fermenters, but Aztreonam avibactam won't cover Pseudomonas, Acinetobacter. It's only for E. coli, Klebsiella. So how do we manage Pseudomonas? So first thing in Pseudomonas, what we would like to know is generally Pseudomonas baseline, it will have an efflux. Whatever the drugs gets in will be thrown out by the organism, or the porin will block the entry of the drug. So major resistant mechanism for Pseudomonas is the drug cannot get in to kill the organism. So if at all, if it gets in, then there is an enzyme NDM. So in US, there is no NDM. Whereas in India, the Pseudomonas, in addition to porin and efflux, NDM is there. Ceftolozane is much more stable to efflux and porin. So ceftolozane, tazobactam, imipenem-relibactam is a soup blockbuster in US and Europe. They can easily manage Pseudomonas. But both the drugs are ineffective in India. So here we need, those drugs are not good. We have to depend largely on the Cefiderocol, which is yet to available, and Cefepime Zidibactam. Otherwise, as of now, difficult to Pseudomonas can be treated with fosfomycin combination. The fosfomycin with imipenem may be a good choice, or fosfomycin with Aztreonam avibactam may be a good choice. Aztreonam avibactam alone is very, very bad choice. So fosfomycin with Aztreonam avibactam or fosfomycin with imipenem is a good choice, especially where you don't want to use colistin, where the kidney damage is there. Otherwise, if colistin can be used, that will be the best choice. So wherever colistin can't be used, fosfomycin plus imipenem, fosfomycin plus Aztreonam avibactam are the good choices. So this is the definition. When we call difficult to treat is, you will get 20% of your isolates like this. Resistant to ceftazidime, cefepime, imipenem, meropenem, piptazo, Aztreonam and levofloxacin. And these are all the resistant mechanism. And what you can give is ceftazidime avibactam, ceftolozane tazobactam, aminoglycosides. These are all can be given in US and Europe, but not in India. And in addition to that, if you have all these resistant, which generally in India we see, the ceftazidime avibactam won't work. These two we don't have. So we are left with only what I said, Cefiderocol, Cefepime, Zidibactam, or as of now only polymyxin. So instead of polymyxin, I have suggested two, imipenem fosfomycin or Aztreonam avibactam plus fosfomycin. Definitely fosfomycin will be highly resistant with more than 128 microgram per ml MIC. But even though it is resistant, when you add two drugs, the combination will help to overcome the infection. So this is non-enzymatic. If you see, if you use ceftazidime avibactam, 50 to 60% you can treat. But you need to have the susceptibility pattern before treating with ceftazidime avibactam. These two is much lower and it's not available in India. Imipenem-relibactam and ceftolozane tazobactam. This is the all India Indian isolates which we characterized. And Aztreonam avibactam alone, if you use for Pseudomonas, chances are very, very less than 10%. So Aztreonam avibactam alone cannot be used for Pseudomonas because Aztreonam completely effluxed from the Pseudomonas. So only when you give with the fosfomycin, it will get inside and it will act. And inherently, if you look at the enzymes, the NDM enzymes are more resistant compared to all others. That's what this slide shows you. And again, I have shown you the comparative results. Cefepime Zidibactam is 100% susceptible to Pseudomonas, whereas Cefiderocol it's only 50%. So if we had Cefiderocol with, so the Cefiderocol is added with the avibactam, now avibactam separately available. If Cefiderocol is available, Cefiderocol avibactam if you add, then it will become 80 to 85% susceptible. So even without Zidibactam you can work. But anyhow, it's an Indian drug, you will have Cefepime Zidibactam. Again, in many difficult to treat individuals in India and outside India, they have used, we spoke to the Wakard company, got the Cefepime and Zidibactam and used on many patients. And wherever we have used, it was quite successful. All the success stories has been published in various journals over the last 3-4 years. So now I move on to the Acinetobacter baumannii. Again, it's OXA48. And if there is the NDM, then it becomes even more challenging to treat. So if it is, do the sulbactam MIC, if it is less than 4, you can give high dose sulbactam. Alone is good enough. But we don't see that in India. We see always more than 128. Even sulbactam, durlobactam is available in India. It may not have a great effect. Only 50% we can treat. And again, sulbactam, durlobactam alone is not good enough. We need to add imipenem here. So majority of our isolates falls here, more than 128. So here, if you give Cefiderocol close to 70%, it will be good. And if you add Avibactam to Cefiderocol close to 90%, it will be successful. Similarly, if the dual enzymes, this is only OXA, this is OXA and NDM. Cefiderocol plus Avibactam, it will push another 20% above. So it's good. So once the Cefiderocol comes, at least that will be very good for us because already we have Avibactam. So for the next 1 year, if we get Cefiderocol, that will be great. Individually, it will take care or to some extent. Even if it is not individually, definitely on adding Avibactam, 90% of the problem is solved. Or if Cefepime Zidibactam comes, almost 95% it will take care. So these were the two important drugs which we are looking forward in this year. So quickly I will go through the non-fermenters. Stewardship maltophilia. There, whatever the drug we are giving, the drug dosage is not good enough to kill the organism. So even what we are seeing, what we are giving, whatever the textbook described dosage are not sufficient enough. So we have to give much more. We don't know how much to give. So that is the situation exists with the Stewardship maltophilia. So it's evolving. In near future, we may have some information in handling the Stewardship maltophilia. So there are a lot of gaps are there with the Stewardship maltophilia. I move on to the Burkholderia Cenocebaceae. Again here, there is no recommendation from microbiology because no drug sustains good level and the tests are not reproducible and the MIC value and clinical outcomes are not correlating. So definitely from the lab side, nothing much we can help for Burkholderia sebaceae complex. We can say this is present, but treating with what drug for how much, how long and how much dose depends upon clinical decision making. So that's the sad part of these two non-fermenters. Burkholderia Cenocebaceae complex and Stenotrophmonas maltophilia. We can give the identity. Beyond that, microbiology lab doesn't have a good evidence to recommend anything to the clinicians. Both these bugs. And now quickly I will finish with the 2-3 drugs which are already approved by FDA some 5-6 years back, but still not available in India. One is omadacycline. So omadacycline, especially for upper respiratory infections or pneumonia, this will be very good, and it is as equal to moxifloxacin. So you can see it's almost in 2 studies, phase 3 trials and phase post-marketing, 81, 82, then both the arms 87, 87, 85. So almost equal to the moxifloxacin. And here, this is oral drug. Again, here also in the post-marketing also, so they had a similar reaction. So for any community acquired pneumonias or to great extent even pneumonias in the ICU can be treated with omadacycline because it's a tetracycline group similar to tigecycline. Hence, you can use this omadacycline. So that's what. And another one is eravacycline. That is oral. Eravacycline is IV, and this can be used as a salvage therapy. And the two important point I want to talk about the eravacycline is superior to tigecycline. And one reason is tigecycline low serum levels is the big fatal part of tigecycline. Whereas eravacycline, it is up to 4 times more than tigecycline, it's available in the blood. So easily it will be very helpful for bacteremia and lung infection. And plasma to epithelial lining fluid is very high with eravacycline. So I can easily say that eravacycline is 4 times better than tigecycline. So we are waiting for this eravacycline to come to India. This is one drug which we can look forward for. And ESBLs, very quickly I will finish. especially for community-acquired urinary tract infection with ESBL. Nearly for 40 years, this is working very well. Mesalinam. Oral is called pevimesalinam and IV it's called mesalinam. So instead of using beta-lactamase inhibitor, piptazo or meropenem, mesalinam either IV or oral will take care of ESBL E. coli in urinary tract infection. So again, that drug is not available. We have tested this. It works 100% very well for ESBL and AMPC. And carbapenem-resistant isolates also 50% it works very well for urinary tract infection. And another important drug is Cefepime N-Metazobactam. This is another very good ESBL. Definitely it's as equal to meropenem. Instead of giving meropenem, you can give Cefepime N-Metazobactam. Quickly, I can easily show that 100% it works very well as equal to meropenem. You can see meropenem 100% and Cefepime N-Metazobactam 100%. So I will tell you why this is very good than piptazo. So in front of piptazo, Cefepime N-Metazobactam is really excellent. You don't need to give 4 times like piptazo. Here it's 3 times a day is good enough and 2-hour infusion is good. The best part of the Cefepime N-Metazobactam is half-life. To protect Cefepime, you need N-Metazobactam. You can see both are available at equal times, 2.7, 2.6. If you look at the piperazoline tazobactam, tazobactam stays for long to protect piperazoline. But unfortunately, the important antibiotic which is protected by tazobactam is not available beyond 1 hour. So this disparity is not there with this combination, Cefepime N-Metazobactam. Second one is even in lung, it's quite good amount is staying. Whereas if piptazo, it won't be there. That's why for all the ESBL infection, including complicated urinary tract infection, and even for community-acquired pneumonia, Cefepime N-Metazobactam can be given. So these are all the various results, which is quite good, and few things are missing. Then the last one is plasmamycin. This is good for again ESBL E. coli alone. And to some extent in certain regions, 50% of the carbapenem-resistant E. coli also it can work. So this is one among the another important aminoglycoside with the ESBL coverage. So with that, I would like to end my talk. Thank you. I'll be more happy to answer your questions.
Yes, sir. Thank you. Thank you for such elaborative and extensive presentation. There was a lot of enlightening information and maybe futuristic options also. But I think there were a lot of questions related to, is this combinations available in India? Is this options available? When are they going to be available and all? I think with this, I will first take quick comments from both our infectious specialists and followed by, I think we'll take those questions. Over to you, Dr. Mona Lisa. What is your viewpoint in current scenario of MDRs and XDRs with carbapenem resistance, and how do you actually see those challenges and your experience?
Thank you for that excellent talk, Balaji sir. Like it took us through all the current scenario of the AMR in the country and the drugs that have been uh, there in the pipeline, and those are in the near future to about to come. So with according to our experience, the carbapenem resistant bugs have increased to a great extent, and like most of like the rest of the country, even our isolates have the similar resistance mechanisms like the NDMs for the enterobacterials, and also the Acinetobacter resistance mechanisms are increasing. So we are left with very few options. So among the current available drugs for the carbapenem resistant enterobacterials, we go ahead with the synergy testing and giving the ceftazidime, Nacubactam, Aztreonam for quite a few of them. And for the Acinetobacter, we have a fewer options like only the polymyxin B based regimens. For three of our patients, we used the Cefepime Zidibactam in our patients, which like one of them was a skull-based osteomyelitis and intra-abdominal infection with the XDR Klebsiella, who had already received 9 to 10 weeks of ceftazidime-avibactam Aztreonam but had not responded. So for that patient, we gave around 6 weeks of the Cefepime Zidibactam, and he responded quite well and is doing well now. And for another patient who had osteomyelitis with vertebral osteomyelitis with this XDR Pseudomonas, we gave this Cefepime Zidibactam. It also worked well. And another patient who had a recurrent septic arthritis post TKR with resistant Acinetobacter, we gave the Cefepime Zidibactam. So we have used this drug across the 3 organisms, and we had a good experience with this drug. So definitely this will be a promising drug for us in the future. And regarding the plasmomycin also, we have used in 4 to 5 of our patients, and it has worked well in the renal patients with renal indications.
Thank you, ma'am, for that overview. This brings me a debated or controversial discussion. Some of our clinicians still stick to use the ceftazidime-avibactam plus azithromycin combination, even though it is still 8th hourly, and unwanted use of ceftazidime. Dr. Balaji sir, do you still feel there is any role of that? Because now we have a combination of avibactam, azithromycin available 6th hourly, 1:3 ratio over a 3 hours infusion. Other than the only indication which I see is OXA48, non-NDM, KPCs, where you don't need an azithromycin. Other than that indication, probably ceftazidime adding to the combinations, any inputs, because of the recent availability of Amlavio with one of those companies. Previously, that combination used to be there, because now we have free drug of avibactam available and
Correct.
also azithromycin available. So your take on that?
Yeah, sure. As you have clearly mentioned, the ceftazidime-avibactam will be very useful only in one situation, that is OXA48 alone, standalone. So we have Klebsiella, very few Klebsiella with the OXA48 alone. So the indicated situations may arise in very little place, very narrow indications only it's there. So in empirical, majority of our therapy is empirical. So in empirical situations, ceftazidime-avibactam may not help. If at all you need to add Aztreonam, Aztreonam with ceftazidime-avibactam. As you correctly pointed out, the only difference between ceftazidime-avibactam plus Aztreonam versus Aztreonam-avibactam is the avibactam component is very less with ceftazidime-avibactam plus Aztreonam. As you said rightly, 3:1 is available when you can have avibactam and Aztreonam. So increasing avibactam will give you better result. So that's why there is no need for ceftazidime. Aztreonam, because in India for every organism it is NDM. And the NDM is, Aztreonam is stable to NDM. Only thing is you have to protect the Aztreonam by giving more avibactam. So ceftazidime doesn't have any role. So Aztreonam avibactam, and even if it is little more avibactam, the side effects are not there. And you can feel free to use Aztreonam avibactam. It's a really good.
That brings me one other controversy.
Yeah,
That is 1:3, which you are
correct.
saying 500 milligrams of avibactam with a gram or 1.5 gram of azithromycin combination.
Correct.
In situations where you said we have a Klebsiella resistance growing up with few of the newer mechanism of resistance, and sometimes we have left with nothing else. The drugs which you mentioned are all probably futuristic drugs which we are expecting in India to be.
Correct.
So in those situations, do I have any scope of using 1:1 in combination, like maybe 1 gram of avibactam with 1.5 gram of azithromycin or something like that, increasing the component of avibactam, giving any better?
Correct. We have to work out and see. So that is good. That's how even as a researcher we will look at it. So increasing the concentration and overcoming the resistant mechanism, that is the very first strategy what you said. So the same thing what you think, we need to put it in the laboratory test and see. And then once it works, then probably we will work on the PK/PD parameters, exactly how much to give. It may not be exactly 1:1. It can be 1:1.25 or 1:1.15, something like that. It will be there. Exactly, we can't see. So that is where we will work on the hollow fiber model, PK/PD, and we will give. And the third step is host factor. So not all the host will react in similar way, respond in similar way. So when we synchronize all the three components, then we will, to great extent, we will know that this combo works very well in this situation. So that's how we evolve ourselves.
Yeah, digital team, why do we see the screen? Bala sir, you have actually stopped screen sharing, right?
Screen saving, it's I'm there now.
Screen sharing. You just stop because we are not able to see you full screen. We are only seeing the screen half closed.
Oh, is it?
Is that everyone seeing?
No, I can see you full screen.
No, we can see this the source screen, the slides, last slide. Thank you, slide is there.
Oh, is it? Then
Digital
it's
team,
not
anybody
a
is there
problem
to
with
help
me.
us? Okay. Sir, you can just say stop screen, stop sharing.
Stop saving. Where it is?
Sharing.
Okay, sorry, 1 second. Yeah.
Yeah. I think we can see you now full screen. So, Dr. Karthik, do you want to add anything to that? I could see you are pointing out. So,
Balaji sir had comprehensively explained the entire AMR situation. I think nothing more to add. But as he said, all these drugs are yet to come. For now, we are just juggling with the colistin and ceftriaxone Aztreonam combination only with plus minus tigecycline. And yes, as he said, pointed out, eravacycline also is a very good drug, but still all these are yet to be made available.
okay. This brings another interesting first question to me in the audience pool. And that is related to how do you test the sensitivity of Avibactam azithromycin? We
Okay.
talk about synergy, we talk about zone of clearance, and then we take a call, even though we start empirically. And now this molecule, Avibactam azithromycin, is available with one of uh, the what you say, the Pfizer or other molecules. Then how do actually you're testing? Is it with the same zone of inhibition by a synergy testing, or do you use E-strip or broth microdilution? What is the technique we use?
Sure. So definitely there is no point in doing synergy testing. That is not recommended now. And synergy testing is also not very clearly defined. So forget about synergy testing. Now very clearly MIC, minimum inhibitory concentration, broth microdilution, and second one is disk diffusion is available. E-test is also available. So for all the things, breakpoints are available with three agencies. It is available with the FDA, it is available with the CLSI, and it is available with the UCAST, European Medical Agency. So like any other drug, disk diffusion interpretative criteria, MIC interpretative criteria, that is same thing for E-test and broth microdilution, same criteria. Disk diffusion criteria, everything is available, and the disk is also available. So all they need to do is purchase the disk or purchase the E-test, and as you do for any other drug, this can be tested in the lab.
Okay. Is this broth microdilution is an integral part of VACTEC or VITEC or other
As of now, it has not come in. If you can do manually, you can do. Otherwise, definitely disk diffusion, everyone can do.
So there is another interesting question suspecting the industrialization of this pharma industry. That is discs provided, E-strip provided by these industries, in your experience, are reliable enough to give a information and a sensitivity?
Yeah, because even the E-test strips undergoes FDA approval. So just 2 months back, only that bioMérieux strip has been approved by FDA. Because last 1 year, that was not available. Lyofelcom, one company was supplying it. because they got the approval. That is more reliable. So it took time for bioMérieux to get the approval. Now it looks that bioMérieux's e-test strips are slightly better than Liofilcum, and either one you can use now.
So that brings to me an interesting recent one of our case where Pseudomonas was MDRO resistant to all the available antibiotic, and we checked कि plasmamycin E strips are showing susceptible to that. How do you take that?
No, it's not that it can't work, it can work. But provided very clearly everywhere, it's said that aminoglycosides should not be used as a monotherapy. So if it can be given along with other drug, definitely you would have given with other drug. So definitely the synergy, it will help.
Do you actually recommend that a combination which you already mentioned about with other drugs, phosphomycin, phospho in combination with aminoglycoside, is it a possible option for pseudo?
More
And
than
other two drugs,
plasmamycin,
with
I won't recommend plasmamycin for Pseudomonas because maybe 10 to 20% it may work, but given a choice of empirical 100 patient, it's better to use imipenem-fosfomycin or Aztreonam avibactam-fosfomycin if you don't want to use cholesterol.
So that was another question, avibactam and phospho. Is it azithromycin phospho or avibactam phospho
Aztreonam avibactam.
plus phospho
Yeah, plus phospho.
or phospho plus imipenem?
Yeah, phosphomycin.
How do those drugs work? Because imipenem and phospho, when we
So
check,
phosphomycin is more like a cholesterol. Only good thing about phosphomycin is it doesn't do any renal toxicity. So all it ruptures, it works on the cell membrane. It ruptures the cell membrane. It allows the Aztreonam avibactam easily to get in and knock off the organism. So this facilitates. It facilitates. See, Acinetobacter cannot be treated without sulbactam. So the backbone of treatment for Acinetobacter is sulbactam. So similarly, if you don't want colistin, then the backbone for Pseudomonas aeruginosa treatment is phosphomycin. So phosphomycin and imipenem is a good drug for Pseudomonas. So you can use imipenem, uh, phosphomycin or Aztreonam avibactam phosphomycin as of now, but there is no big body of literature. This is purely from Indian isolates, what we have tested and clinically successful we have experienced, I am sharing.
and
But the best
how,
overall evidence is only with the two drugs.
how,
Cefiderocol.
how do we check that? We have no way to check it.
Yeah, in our lab we do time kill assay, something like that. Time kill assay it's called. So when we combine first we do determine the MIC of phosphomycin separately, Aztreonam avibactam separately. Both will be resistant. We had both like a checkerboard method, and what we do is every 1 hour we will look for the killing effect, log killing. So we subculture, next day morning we look at the colony count. So when you, after adding both the drugs, every hour when we subculture and do the colony count, before 8 hours, if there is a reduction of more than 2 log kill, then it is effective. And with this combination, we have seen up to 3 and 4 log kill. So which is really superior. Anything 1 and above 1 is good, and 1 and 2 are borderline, and definitely above 2 it will be excellent. And the time taken to kill should be less than 8 hours. Why it's less than 8 hours? Because for every 8 hours you give loading doses, in divided doses you give. So we expect the killing to happen at 6 to 8, before 6 to 8 hours. In reality, when you give 3 times a day, then TID, that works very well. So time kill assay it's called, and we do in our lab that experiment.
The other two questions which are similar of availability of eravacycline and cefiderocol, you repeatedly mentioned when you mentioned about combinations and monotherapies. Availability may be in this year or so. So when are we expecting in India? Is there any
See,
broad?
Cefiderocol, it's already, the Cefiderocol has been given with high subsidized rate by the WHO. So except Europe and America, it's full cost. Cefiderocol is sold, each dose is $1,200. So every day they are spending $1,200 in US, 1 lakh, 1.5 lakh rupee. Whereas in India, the government has given highly subsidized. The WHO has subsidized for all the middle income countries. So the orchid is taken, and in India it is going to be manufactured in Himachal Pradesh, and this drug will be distributed for 150 countries with the subsidized rate. So in a large scale production, they are doing it. What I have learned from Orchid is the one which does. Probably in another 6 months' time, they should get it done.
Okay.
So
And
meanwhile, they have to get the FDA,
what,
sorry, Indian regulatory approval they should take.
what about eravacycline, sir?
Eravacycline, again, at least Cefiderocol, it was bought over by the WHO and is giving. Eravacycline, some company from India has to approach the parent company and they have to take rights and come here and then they have to sell it. And I don't know, Eravacycline really, that is also sold for $600, $700 each dose. I don't know how to India at what price they will give. So Eravacycline, I am skeptical. For lower price, getting access in India will be too difficult. Whereas Cefiderocol, definitely yes, because the Shionogi Japan company has given to WHO and WHO is distributing for highly subsidized price.
So,
Cefiderocol.
so we will expect a Cefiderocol may be available in this year or
This year end. This year end. It's suppose if they would have been very active, by this time it should have been available because 2 years back this have all been sanctioned and approved. Nearly they are struggling to manufacture in large scale. So it should be available at the end of this year.
and Zidibactam availability, sir, when are we?
That is readily available. Only thing is, once the regulatory approval is given, immediately they will bring it to the market.
So maybe March or maybe June, if the regulatory authority happens, it may.
Done immediately 1 or 2 months, but that will be very, very expensive than Cefiderocol.
In India, Zidibactam will be expensive.
Yeah, Cefepime Zidibactam will be more expensive than any other drug available today.
In India, you said it will be cheaper than other countries. That's what you were talking about.
See, in abroad, if they are selling it for 1.5 lakhs, in India, at least for 15,000 rupees, they will give
1.5.
1.5. I'm just get.
This
I,
is a
this is
guess.
approximately. So
For
I
one
don't.
dose.
So it will be something like 15. They can't give for because Aztreonam maybe Bactam they are selling it for 5, 6, 7,000 rupees.
7,000
So
rupees.
I
Yeah.
think Cefepime Zidibactam, even if they sell it for 20 or 25, I won't be surprised because they have put in 25 years of research.
But this brings an interesting change in the way we manage Acinetobacter. I think Cefiderocol will bring an additional drug to India to combine with Sulbactam. And I
Maybe
hear
Bactam.
repeatedly you were talking about Sulbactam based therapy for Acinetobacter as a prime first line. Yeah. So we still believe that many of our clinicians, including ID fraternity, still bets on colistin-based, polymyxin-based therapy. What is your take on that in India?
Uh, Actually, because we have NDM, whereas in US and Europe, they have no NDM in Acinetobacter. It's only Oxa for 23. So that way, Sulbactam works very well. And the data to prove also it's quite good with the, because we don't have any other data. That's the reason still we continue to talk about Sulbactam. If there is no NDM, still we can manage with a good amount of Sulbactam and tigecycline, minocycline. It will work. When the NDM comes, then definitely minocycline or tigecycline has to be there.
There is a different trend we are seeing in most of our hospitals, including mine. I hope that both of my ID colleagues also will agree with me. We are seeing a stiff resistance in minocycline. We very comfortably added minocycline to existing combinations to sulbactams or polymyxins earlier. But nowadays, even for the lung, when we see a ET secretions or a bowel sample is growing Acinetobacter, we see minocycline being resistant with higher MICs. Some of the times, TG cycline is susceptible, intermediate, or resistance. But Mino consistently has shown to be resistant in more than 80% of the situations. What is your
Right. Yeah, that's true. Because minocycline, year after year, they are bringing down the MIC levels. Generally, the blood levels of minocycline is better than TG cycline. That's the reason we are promoting minocycline rather than TG cycline. Because even TG cycline double dose you have to give.
yes.
Minocycline. But unfortunately, if you look at the microbiology side, the MIC breakpoints, what was there 8, they made it into 4, now they made it into 2. So majority of them falls into intermediate or resistant category than susceptible ones. So actually it's losing its effect on Acinetobacter because Acinetobacter has got multiple resistant mechanisms now.
So do you think now in this scenario, when my Mino is resistant and TG is susceptible or intermediate, what should be my drug of choice when I have dealing with lung or a blood? I will avoid both of them or choose one other over the other.
See, when a lung is there, it's always better to have sulbactam. Of all the beta-lactams, sulbactam has got highest lung penetration. None of the cephalosporin or even carbapenems have got that much of a lung penetration. Sulbactam is the one drug which has got a high lung penetration. And if you look at Acinetobacter, even in the ward, you don't see cases. It will be in the ICU patients only you see the Acinetobacter, especially ventilated cases, you will see the Acinetobacter. Even bloodstream infection also that much may not be there. Ventilated associated pneumonia,
That's
bloodstream infection, it will be there. So it becomes all the more important for the given situation and the syndrome. Sulbactam will be, it's a must. So that's the reason you give any combination, even cholesterol you give, cholesterol should be given with sulbactam.
okay. And the dose of sulbactam remains.
Because why sulbactam will take care of the lung situation, cholesterol will take care of the bloodstream infection. Because now, even though the cholesterol won't get into the lung, still it can clear the bug if it is there in the bloodstream. So it can reduce the burden, and even minimal amount of entry into the lung will enhances the activity of sulbactam.
The dose will vary between 9 grams to 12 grams. What is the dose sulbactam you use in?
Up to 9 you can give. When you are adding cholesterol, 9 is good enough. So
9.
still cholesterol sulbactam will be the best choice.
And in over a time when Cefiderocol will be available, you have a availability of Cefiderocol plus sulbactam versus colistin plus sulbactam. Which one will you prefer?
Either instead of either Cefiderocol sulbactam, but we have seen more than sulbactam, Cefiderocol Avibactam also works very well.
For Acinetobacter.
Lung infection, Acinetobacter.
Okay, we have availability of Avibactam, so instead.
Separately, we have now in India. So when Cefiderocol alone only will come. So what you can do is add Avibactam and Cefiderocol, 90% of the problem will be solved.
And the dosing which has been studied, sir, that's a very.
Still nobody has studied the dosing.
Okay.
So somewhere we have to start and proceed.
Okay, I think we had a lot of extensive discussion. Dr. Mona Lisa, any points to ask to sir? There are a lot of questions yet, but I think when Dr. Balaji is available on floor, nobody will leave him without asking questions in multiple platforms. But any questions from you?
I think sir answered almost all the queries. Nothing more specific to be asked.
Okay, and the concern related to Zidibactam, I think you had a couple of cases or more than that, and a couple of them have also been published in different year with the Zidibactam. I have a personal experience in a couple of cases with Pseudomonas being PDR, and we used without any testing. That's one an empiric on a compassionate ground. The family able to bring that molecule to us. So we see a promising results in Pseudomonas and even in Klebsiella and Acinetobacter. So what was your experience in those cases, and what is your internal information, when is this drug going to be available to you?
Any moment in India, it should come. They've asked for some more queries. In another 3-4 months, I think if everything comes, it should be there, sir, any moment. Even the company doesn't know. It's all rest with the regulators. If they don't ask more questions, it will be available.
Mona Lisa ma'am, any information to you? When is it going to be available?
Balaji sir will have the most authentic information, not us.
No, I don't. Off late, I have not met them for nearly 3-4 months. So currently, I don't know the updates.
You brought some of those quinolones into the picture, talking about they covering ESBLs and some of them also for a carbapenem resistance E. coli in urinary tract. And the same company or the same pharmaceutical industry is bringing levonorifloxacin for more of gram-positive cocci in Staph aureus cocci. Any interactions with on that side, even though we more focus today on gram-negative side, how do you place that molecule for community-acquired pneumonia, skin and soft tissue infections, where you see gram-negatives which are more susceptible?
Definitely, levonorifloxacin works very well for Staph aureus and MRSA. So, in fact, I can place that far better than vancomycin, teicoplanin. So, it's no point when we have a levonorifloxacin, I don't think that you should use Vanco and Tico. So, this is really one of the best drug. The MICs are very low, especially for the lung cases, unbeatable. For bloodstream infection, it's unbeatable. And they have shown a lot of good results with diabetic foot and bone and joint infections. So this generally fluoroquinolone has got a high tissue penetration, unbeatable. That class is best for tissue penetration. So for diabetic foot and orthopedic infections, really that is wonderful drug, as well as for bloodstream infection and pneumonia. So overall for Staph aureus, because the problem with the Staph aureus is if you don't aggressively treat within 2-3 days, then the chances of miliary dissemination, means endovascular infection or endocarditis, is very high. And if not treated, because vancomycin may not achieve a steady state concentration for 4 doses, thereafter only slowly picks up. So the delay in aggressive treatment, sometimes 10 to 15% of the individuals land up with endovascular infection or endocarditis. So again, vancomycin is a slow bactericidal, whereas this levonorifloxacin is very highly bactericidal. So that way the drug really works very well, levonorifloxacin. When it comes to pneumonia, I prefer nafithromycin. Again, it comes from the same company. So we have done nearly for 7 years, we were working on nafithromycin, testing with the different.
It's available in the market, sir?
It's available in the market, and exclusively they are giving it for pulmonologist. For OPD, it's an oral tablet. The advantage of the drug is it takes care of community-acquired pneumonia, Haemophilus influenza, Streptococcus pneumonia, Moraxella, and it takes care of all the atypical pneumonias. Mycoplasma, chlamydia, legionella. We don't have much of a chlamydia and legionella, but lot of mycoplasma is there. So for upper respiratory infection, community acquired infection, nafithromycin seems to be good, and it's only 1 tablet per day, 3 days only. It's only 3 days therapy.
So I think before we wind up the last questions, there is unending questions list there, but we will wind up. You spoke about the Strino Burkhold area, and to all our surprise, you made a big statement saying we don't know what is the dose, what is the drug which works best to them. Even on paper, many drugs look sensitive. We get a report,
Correct.
we get a MICs. So it's a kind of a scary statement to many of us. And even we face some of the times where the report also was a PDR. We don't know where to actually. Dr. Karthik, Dr. Mona Lisa were also been witnessing some of those situations where we played around with Avibactam combination with Aztreonams, combined sometimes this levonorifloxacin when it was shown to be susceptible on a E-strips and all. Any take on that before we conclude? Last.
I would like to mention about Stenotropomonas maltophilia. the problem is all the drugs will be susceptible on the plate and we will be giving susceptible. But the problem is the PK/PD. The right dose to be achieved is the question. As of now, whatever the test result has come from the lab shows that the standard dose therapy doesn't works. So the dose has to go beyond the standard dose. But we don't know how much higher we have to take it. That is the challenging part. And most promising drug to treat Stenotropomonas maltophilia today is in with us, we are having Aztreonam avibactam to great extent. That is good. And better than that is the Cefiderocol. So one thing is very clear. The best drug, winning drug for Stenotropomonas maltophilia is Cefiderocol. There is no doubt about it. It's very strong. But Aztreonam avibactam is the second best as of now. And then thereafter, still the cotrimoxazole can work, levofloxacin can work, but you need to give not as a monotherapy, you need to give as a dual therapy. Two drugs therapy you have to give. So that is the current understanding.
Same things happen with Burkholderia cepacia. We do
Also, sir, because
surgery.
again, PKPD is the problem. So if you give two drugs, then it will be good enough. Until we understand better, monotherapy is not good.
Thank you, sir. I think it's been more than 80 minutes or so, and a good number of hundreds of people are logging in this late hours of a day. And that's only because it's Dr. Balaji and his talk and it's his wisdom. A lot of learning experience for all of us being a part of your academic session. It always been a privilege, and we all enjoy the way you carry the talk, way you bring all those spectrum of your own experience, blend with the worldwide data, real world scenarios, possibilities, combination, futuristic, and many more. This was a wonderful session and one of the best sessions we had in the recent times, sir. Thank you very much for accepting our invitation and
Thank you.
and
Sure.
thank you,
Thank you.
Dr. Mona Lisa ma'am and Dr. Karthik Vedula for being here for the last 1.5 years. And it was added our program to a specialist angle by presence of both of you. And this is probably an honor to Dr. Balaji sir from both of you being here and participating here. Thank you for being here with us.
Thank you very much, sir.
Thank
It
you.
was really enlightening talk. Thank you, sir.
Karthik sir, you're telling something.
Yeah, thank you, sir. Yeah, Balaji sir enlightened a lot with the data and all unpublished data also. So that gave us a good insight.
Thank you, sir. We hope it will reach to
Thank you, Mona Lisa.
thousands of
Thank you.
participants in that, and we had a good number of participants still putting questions, and there are a lot of actually appreciations blended with those questions. Thank you, sir.
Thank you. Sure.
That I conclude the session. Thank you.
Bye-bye. Bye.
Bye-bye, sir. Thank you. Yay.